I'm Angry Bill, this is Pre-Hospital Wisdom. Kind of want to start a fight a little bit. There's a lot of paramedics that I've seen or talked to that feel like automated blood pressure cuff on like a cardiac monitor or life pack or something is essentially just a random number generator. I'm here to tell you, anyone that says NIBP on a life pack is a random number generator is an idiot. What they're saying is every OR, every flight system, every ER, every place that uses NIBP, non-invasive blood pressure, the automated cuff, however it is, every single one of those, you're saying there's actually a secret. They're meaningless. And you're the only one that knows the secrets. No anesthesiologist, no OR nurse, no one else has ever figured out the secret. Give me a break. Normally I'd have a whole lot of studies and backup to show that, but I ain't dealing with it. There's too much on Google. A quick search of Google Scholar will get you all of the information that you're ever looking for. So to me, the blood pressure tool that I'm using is like any other tool. I need to choose the correct one for the correct situation. So saying never or always makes no sense to me. Here's another quick point. If you get a different number from an automated blood pressure cuff very consistently, how do you know you're the right one? You're telling me that the cuff on the monitor is less accurate than a rookie provider of some sort who deflates a cuff 3 times on a pale diaphoretic patient, has a look on their face like they're trying to divide a 4-digit number by a negative fraction, and then tells you 120/80. You're right, that's a lot better than the life pack. So, in an ambulance, the choices I have is a manual blood pressure, where I auscultate or palpate a blood pressure with a sphygmomanometer and inflate it and deflate it and listen for it or feel for it. The other one is to put a cuff on, hit go, and run it off of that. Both have their advantages and drawbacks, their positive and negatives, so let's talk about this real quick. So a manual cuff, I'll be honest, is one of the first things that I usually do. It's pretty easy once you learn how to use it, and especially if you're in a quiet environment. There's stuff like helicopters or even ambulances driving down a noisy road or with sirens on or a whole lot of people talking, that the noise level makes it difficult to auscultate a blood pressure. Not impossible, just difficult. But leaving that aside, noise can be a bit of a problem. There's also a bit of a learning curve. If you've ever watched an EMT take their first few blood pressures, it's not the easiest thing ever, I'm gonna say. When I'm taking a manual blood pressure, my attention is on the manual blood pressure. It's not about thinking what my next moves are, reprioritizing my call, talking to the patient, talking to my partner. It's about the blood pressure. The other thing with the manual blood pressure is that it needs a stethoscope within reach. There's just some times where I left it up front on the dash or something like that. And I could send my partner around real quick and get that. That's probably the best answer. But if you don't have your stethoscope right there with you, you're not auscultating a blood pressure, are you? So what I'm going to call non-invasive blood pressure is the automated blood pressure on a monitor, on a life pack. And NIBP uses oscillometric monitoring to come up with a mean arterial pressure and then tell you the systolic and diastolic numbers. You need to understand how it works, how that oscillations of pressure within the cuff itself and the tubing makes a difference. So it doesn't work as well when someone is talking, and especially if they're moving their hands and talking a whole lot. Each one of these little movements with their hands causes different pressure changes within that arm, within different muscles within the whole arm that end up confusing the blood pressure cuff. It's also not especially good when dealing with atrial fibrillation or a lot of ectopy. Those differential R to R periods is causing differential filling, which causes differential pressures even beat to beat. And so those are difficult to auscultate, but it's impossible to automate. It'll keep cycling and cycling and cycling. So something that's profoundly irregular can present problems to an automated blood pressure cuff. Besides patient movement, road bumps and other oscillations or bumps or movements can affect the NIBP. On the positive side, I don't have to deal with my attention being focused into a blood pressure with the NIBP. I can cycle it, think about other things, do other things, have other things in my hands. I can even be listening to breath sounds while that blood pressure is going on. You can't do that with a manual cuff. Most of the negatives are taken away by patient positioning, tubing positioning, the coil of tubing that connects the cuff to the monitor, setting that up so it's not just like bouncing down the road. That's pretty important. And remember, you can always set it to regularly monitor what the patient's pressure is doing. You can set the cycle time from 2 minutes up to more than an hour. And so just setting it and getting a repeated blood pressure without having to say, it feels like a long time since I've done a blood pressure, I need to do another one. Regular monitoring of that blood pressure, whether the patient is sick or not sick, makes a big difference. Palpated blood pressures are another option. They're quick. Oftentimes when someone looks unstable or feels a little bit unstable, I will get a quick palpated blood pressure to get an idea, what am I dealing with as a systolic number. Remember, palpated blood pressure doesn't give you a diastolic number, nor does it give you a mean arterial pressure. Those are important for driving care, and especially for driving future care in the emergency department and whatnot. So any palpated pressure to me is either a temporizing measure or a profoundly lazy provider. The final option doesn't come up all that often. It's arterial line pressure monitoring. This is actually the best if you're involved in hemodynamic medication administration like pressors or antihypertensives, and is especially good in something irregular like AFib. The ability of an art line to monitor beat to beat means it doesn't get confused by those different spikes in pressure after a longer R to R time. So in the end, manually auscultating a blood pressure or using the NIBP function on a LifePak essentially is a choice between tools. You need to weigh the cost and benefit of each and not just knee-jerk throw out one of the options to say, I never automate a blood pressure, or I always auscultate a pressure. So saying never or always is oversimplifying at best and stupid and closed-minded at worst. So let me know what you think down in the comments. This is Angry Bill for Pre-Hospital Wisdom. You know all the YouTube stuff. Like, subscribe, share, especially subscribe. Till next time, see ya.